Okay.
Very good. The first slide.
1 second.
With your presentation.
Yeah.
You ready or?
Yeah, I'm ready.
Okay.
So thank you, everyone. And it's a great pleasure. And it's a bit sad that I'm not there. I wanted to see Gavi and the other Bezev colleagues, but also Huib and others. So it's a bit unfortunate. But I'll talk about universal health coverage and assistive technology. I hope it works. So aging and disability, we have to really understand the context now, more in terms of aging and disability. People living longer everywhere. And as we grow older, all of us will experience disability. It is no more about others, it is about all of us. Some will experience disability since birth, some will experience at early age, but majority will experience as they grow older. Aging and gradual functional decline are almost synonyms. No medicine or vaccine can either stop or reverse it. So 21st century major drivers of disability and rehabilitation, as we see, is children, mostly cerebral palsy, congenital anomalies, adults, young adults, spinal cord injuries or amputees. And the most population will need rehab services, assistive technology, are older people, especially NCD, stroke, diabetes. So 21st century major drivers of healthcare will be aging, NCD, and disability. We have to keep these three scenarios in mind. It's not about what we used to experience in last century or even 10, 20 years ago. We are talking about now and the future. And aging, NCD, and disability will really determine, they'll be the major drivers of the healthcare. So 21st century healthcare is also about assistive care. Now, when we talked 1978 Alma Ata, we said healthcare should be preventive, promotive, curative, and rehabilitative. And then in recent years, we added palliative. But there's a big stage we all have missed is the assistive care. Because nobody will go straight away either from curative or rehabilitative phase to the palliative. There's a 20, 30 years age in between. And that's why the assistive care is so important in 21st century. So 21st century healthcare should be preventive, promotive, curative, rehabilitative, assistive, and palliative. And when we say assistive care, we talk about the human support as well as technology and the environment. So it's how we can connect people, technology, and environment together to make a better living for everybody. So 21st century is really beyond medicines and vaccines. It's no more only dependent on the pharma industry. It has to go beyond. And this is what we are seeing across the world, whether it's a developing country or developed country, the people, most majority of people who need services are older people. But there is a big problem. is like a digital divide, the north and south technology divide. And the biggest problem is the cost and the existing healthcare model. Mostly in South, they copied the Western or Northern models of healthcare, which is difficult to sustain in North. So it's more challenging to sustain it in South. As a result, majority of people with disabilities or functional decline, they're dependent. You will not see many people in the shopping malls on the outside. Older people are working independently like we see in Geneva or in Europe. So mostly older people are dependent on their family members or the neighbors. As a result, 90% people don't have access to assistive devices. Give you an example of hearing aid. The hearing aid, the steps you read to access a hearing aid, on one hand, medical doctor, ENT doctor, audiologist, technician, and on another hand, developer, manufacturer, distributor, retailer, which increases the cost of hearing aid from $100. The original hearing aid should not cost more than $100, but it comes to $5,000 because of the system, because of the different other issues. So it's a 20th century for 21st century model, and it doesn't work. Nobody in the developing world, or very few people, I will not say nobody, very few people in the developing world can access $5,000 hearing aid. So there's a cost is a huge factor. And problem of access is really more acute in global South. There is hardly political will. Though more than 170 countries ratified or signed CRPD, but it doesn't make any real sense or real change in the practical world. And this assistive technology falls between the cracks, whether it's a Ministry of Health, Ministry of Social Welfare, Ministry of Education, or NGO. Cost of products and services are phenomenal. In some wheelchairs are more expensive than Mercedes car. I just wonder why, what is there in a wheelchair? So it should be as expensive as an advanced automobile. Then we also have an issue of trained personnel, availability of services. Most services are in the big cities, where the people live in rural areas. And the distance and transport is more challenging for disabled people to have accessible transport to reach to the services. And as a result, majority in the developing world still depends on donation or charity. So, and the quality and regulations is a really, nobody knows. So we, WHO, we follow this AT ecosystem. We are saying that, either or will not work. It has to go as a together. So we say 5P ecosystem: people-centered policy, products, personnel, and provision. This all has to go hand in hand to make it work. So to meet this huge gap of 90% people in need of not having services, so on 4th July 2014, WHO established GATE, is a global cooperation on assistive technology, following the Article 32 of the CRPD to strengthen global cooperation and also to strengthen the SDG Goal 17, the partnership. So since then, in 6 years of GATE, we have achieved quite a lot significantly. We had international conferences where people like Angela Merkel, Chinese Prime Minister, all were talking about assistive technology. We developed the essential priority assistive products list, like essential medicines list. We also have a World Health Assembly resolution. We created 80 scale, 80, 20, 30. So we achieved a lot in last 6 years. And that's also quite significant how we changing the scenario. Now coming to the SDG goal 3, health and well-being. The target 3.8, which talks about universal health coverage. And it talks about everything, but it forgets the medical devices, assistive devices. We say that, they ran out of the ink. So it says effective, quality, affordable, essential medicines and vaccines. Many people need other services too, and that's what is missing. Other products, like assistive products, are missing completely. And that's a historical blunder and mistake. And so what we did, we are trying to promote assistive product as an essential health product, as essential as medicines and vaccines for people in need. And that's making a quite a big push. But then the COVID came. And when COVID came, the traditional service provision model everywhere got disrupted. On your right, this is a rehab center or assistive technology center in the Wuhan hospital, which is assistive technology center in the 15th floor, or in Mobility India in India, or Afghanistan, Pakistan, everywhere, all the facilities closed down during COVID. So what can we think of assistive care in new normal? How we can really make it better? So in new normal and the post-COVID, we have to think of new model of service delivery. And that's what we are promoting, the tele-AT concept, where we use make optimum use of technology and available human resources to provide and maintain assistive technology at home. Home-based intervention with remote support, quite a bit like a home delivery. So going beyond ICT, make available technology from drone to 3D printing, robots, everything possible to ensure people have a quality service or they have service at home. We are talking about total innovation and USC, PSC on one hand, and the market on the other hand. Because if we do not see the market opportunities and if we don't open the market, the big players will never get involved. So we are trying to see that how digital and assistive technology for aging and disabled open a new market. And we have made some inroads, but more to happen. So thank you very much. And this is our GATE community. So we request you to join our GATE community. We have more than 1,500 organizations and individuals as a members from 119 countries. And I also like to give thank you to Government of Norway and Government of Germany, BMZ, to give us some support to kickstart this new initiative in the new normal, the tele-AT. Thank you. Over.
Thank you very much for this presentation. We'll do the questions and answers after the last presentation. Is Alarcos with us now, or Alarcos? No. So I would suggest we continue with enablement with Huib Cornielje. Is this fine for you?
Alarcos is waiting 1 minute. You take over host, so then you can.
Alarcos is coming in.
Yeah, you take over the host rights.
Chapal, you have to stop sharing your screen in order for Huib to show his presentation. Chapal?
I'm desperately trying that. So can you take because the hostship has problems. So can you?
Can you stop sharing? I think you're still on sharing your screen. Can you cancel that? Can you get out of your screen, please? Yes, very good. Thank you. Okay, I give Huib Cornielje from Enablement the floor. Please, Huib.
Okay.
Hybrid workshops. Huib, your mic is still muted. We cannot hear you.
I see.
Now it's fine, yeah.
Now you can see me. And I am not yet a host, I think. So if someone can make me the host, then I can share also my presentation.
I think. Chapal, can you give, you're still the host of the presentation, can you give please the host to Huib? How does he do that? Can we tell him, or I don't know? Chapal, you're still the host. Can you give the host to Huib? How do you do that?
But how I do it? Because I have not seen it anywhere.
You can see it on the screen that you are the host.
I think there's on the right side of your screen, Chapal, there is, you can leave actually, there's a red button. Which
Yes.
press, but then you leave the meeting.
3 buttons.
Oh, then you leave the meeting, I see.
Yeah, these 3 buttons say mute audio, stop video, rename, pin video. No. It's crazy. How you gave me the authority? Can't you take the authority back?
I have no idea. Should I do it otherwise without the presentation? It is not
Okay,
so nice.
I did it. You try this multiple screen sharing. There is an option I found. Can you share your screen, Huib?
Chapal, can you hear me?
Yeah,
Yes?
it's possible.
Okay.
Huib? Yeah.
Yeah, it's possible.
Yeah, okay, great. It worked.
And, fantastic.
Fantastic.
Okay, good afternoon, ladies and gentlemen. The COVID-19 pandemic makes painfully clear that conventional methods of providing rehabilitation won't work if people are not able to move, if they are not able to visit health centers, or if they are not being able to visited by people at their homes by rehabilitation providers. Besides, in general, I am afraid that just increasing the numbers of conventional rehabilitation staff in low and middle income countries hardly will contribute, at least not in the short term, to better access to rehabilitation services for the poorest of the poor. Who are those people? Who are those poorest of the poor? I think those are the people who suffer from material poverty, but they suffer very often also from relational poverty because they are poorly educated and they have poor chances to get a decent job. And it is very often those who suffer also from cognitive poverty, those who have to deal with significant levels of stigma and self-stigma. It is at the same time those who are often most in need of rehabilitation services. People, adults and children who live on the fringes of society in the slums of the big cities and in the periphery of the countries where rehabilitation resources hardly exist. And if they exist, they are often not accessible and are often of poor quality as well. Besides, very often conventional rehabilitation professionals don't want to live in such circumstances or work in such circumstances. In those countries, where numbers of mainly physiotherapists increased over the past decades, many don't want to work in the public sector where payments are low and employment conditions are poor. At the same time, such countries are often faced with a serious brain drain, and on top of it, very often also a skills drain of rehabilitation staff. I mean, the best ones leave for greener pastures or use their training as a jumping board for a better life. And I'm not blaming them, by the way. There are countries which have seen an increase in numbers and rates of conventional rehabilitation workers, mainly physiotherapists, over the past years. But the situation for the poorest of the poor is often getting worse because such countries have become increasingly inequitable and the gap between the haves and the have-nots have been increasing. Trying to share my whole screen. Yeah, that's better. Yeah. For some time, we had hoped that rehabilitation workers could do a large number of the tasks that normally would be done by professionals. However, increasingly we have witnessed that community-based rehabilitation has broadened into more community-based inclusive development, very often at the expense of solid training in the field of rehabilitation. The effect nowadays is that increasingly we are confronted with very poorly trained field workers who may know a lot about disability rights and may know a lot about disability inclusive development, but lack the ability to give even the most simple advice to a mother of a child with cerebral palsy. Enablement noticed the challenges faced by rehabilitation field workers, as well as by other service providers being involved in community work and outreach, and decided to implement what the late author Mike Miles wrote already in the 80s of the last century when he was working in Pakistan. He wrote in one of his publications, invest in IBR. And he was not meaning institution-based rehabilitation, but he meant invest in information-based rehabilitation in order to empower the masses with good quality information. Enablement, as a very small role player in the world of disability and development globally, decided a few years ago to focus on the dissemination of information about rehabilitation in order to enhance the capacity of field workers, enabling them to design rehabilitation interventions, supporting them to provide care and support and refer clients, people with disabilities, where necessary to other levels of healthcare and social services. And in practice, it meant that we developed a smartphone application, which we called the Rehab. It actually is more or less a digital form of the still popular manual of David Werner, where disabled village children, one could say, an updated and more modern manual, quotation marks, based on the ICF. So using a broad and globally used framework as the basis for a practical and much needed source of information. The Rehab will consist of at least, but even more than 20 plus what we call disability chapters, focusing on different types of disabilities. And you can see on this slide 8 ones which have been released and which have been used in a number of countries at the moment: amputation, burns, cerebral palsy, clubfoot, leprosy, low vision, spinal cord injury, and stroke. And quite a number of them are currently being developed, and the green ones which you are seeing there are basically ready, but we are not uploading them at this moment yet. These chapters are being developed by teams of usually 5 to 7 experts coming from different disciplines, different organizations, and different countries. I mentioned already the ICF structure, which was mentioned this morning, and I think this afternoon also at the main conference, as a recognizable international framework and structure. And one who knows actually very well the framework does realize that in our rehab, we are not focusing only on purely medical or therapeutic aspects of rehabilitation, but we have a very comprehensive view on rehabilitation, albeit we pay a lot of attention to especially the hardcore rehabilitation aspects as well. As mentioned, various organizations have been involved over the past 2 to 3 years in contributing time, ideas, and funding. And without their support, this development never would have been possible. It is the joint effort of those organizations and our staff to ultimately leading to an app that is meaningful to field workers as well as people whom they are serving. Currently, based on testing and field experiences, we are moving into a new development, and we are going to develop a content management system, which allows us to do more ourselves and make use of a more independent, and to be more independent actually from our app builder. We are going to redesign the app architecture, and we will include new modules. And I'm showing here in this slide the different new models that will be part of the app. The information part we do have already. That's purely information, useful for the field worker, but maybe very useful for clients as well, for people who are being served by the field workers. There will be an assessment module added to the rehab, a goal setting module, a module that helps in setting actually the rehabilitation interventions. The app can be used to keep client records. It provides also for referral options, and one may realize that you then need a very contextualized aspect also in the app. And it will give, last but not least, also an option for information management. We hope and expect also that the rehab is going to become an important resource for rehabilitation field workers and the people whom they serve. I started my presentation with referring to COVID-19, and I would like to finish with it as well, but would like to say also that currently we are in the process of field testing all different chapters. We are translating the chapters in various languages, from French to Portuguese, but also from Tajik into Bahasa Indonesia, from Vietnamese into Amharic, and basically the app should become available in all languages that are being spoken in different countries where we are working and where our organizations are working. But I come back to the COVID-19 pandemic. And the COVID-19 pandemic tells us that we need to step up our efforts to reach the poorest of the poor and offer them access to information about disability and give them at the same time information about possible forms of rehabilitation as well. Try to avoid the term empowerment, but basically, it is what we so often call, we need to empower actually people, and we have an opportunity these days because we have the technology on our side. And whereas Chapal was referring to the gap between the South and the North, he is right. I think there is still a gap, but increasingly we see also that a lot of countries, especially in Asia, but increasingly also in Africa, get better and better access to internet facilities as well. Now, we believe very strongly that the rehab can play a very important role in the further development of making vital information available for people with disabilities and their families, and make also tools available for rehabilitation field workers so that they can do their work more effectively and more efficiently. Thank you very much. Well, I'm not a host anymore. I'm not sure.
Yeah, we can see you. Thank you very much. We can see you, Huib. And there is Alarcos, yes.
Yeah, hi.
Okay.
Hi to everyone, and good afternoon. I'm sorry for before that I couldn't be here at the beginning for whatever reasons. I couldn't find my way to this room, so that was a little bit of a challenge.
Okay, we just said, Alarcos, that you are the last presenter, about 10 minutes most. And then if you can stay with us for, we'll have less time than we expected, so 10 minutes of questions and answers. And then we'll have these guiding questions we'll share with the audience online and the people who are here in Berlin. And this will be the the working group, and then we'll come up with solutions and recommendations from the audience online and of course from you. So if you can stay with us until the end of the session, the three of you, that would be great. Okay,
Yeah.
the floor is to you, to your presentation.
Yeah. Okay,
Thank
great.
you.
Thank you. And I hope that I will be very brief so that we have more time for discussion. And look, what I thought it is important based on the topic of this session is to address the question: how can rehabilitation become more actually a political priority, I would say again, in health policy? And I would like to present very briefly what is the strategy that WHO has been following so far in order to achieve that. And our starting point has always been, look, there is a tremendous need for rehabilitation services. We also have a number today that we are promoting, and we have the evidence behind that 2.4 billion people will need rehabilitation at least once in their lifetime. It is actually portray an underestimation because, of course, many of these 2.4 billion people will need very regularly rehabilitation along the lifespan, and many people would also need rehabilitation services across the life course. But at least we have a number now that portray that need. The challenge that we identify in countries is that demand is very low, as well as the supply is very low. And that, of course, we consider that this low demand has to do with the low awareness that exists for the need of rehabilitation services in countries, and the low supply is related with the low capacity in countries. And that has defined the strategy of WHO to move this agenda forward on rehabilitation. And it is a dual strategy to increase the demand and to increase the supply. On the one hand is evidence-based advocacy, and on the other hand is increase the technical capacity in countries. And for the sake of really advocacy and to do evidence-based advocacy was the reason why we launched this call for action that we call Rehabilitation 2030. And the narrative for Rehabilitation 2030 is very straightforward. At the end of the day, what we always say is rehabilitation needs are across the lifespan. Rehabilitation services need to be available for everyone with health conditions and impairments that experience disability or limitations in functioning. Rehabilitation needs to be integrated in the continuum of care, and it needs to be strengthened through the health system. And we have many advocacy documents in the meantime in order to strengthen these messages from an evidence-based point of view. And in terms of technical capacity, we are developing many different resources, and again, with the purpose of increase the capacity in countries to strengthen the health system to provide those rehabilitation services. One of the main projects that we are doing in collaboration with, in the meantime, over 350 rehabilitation professionals from around the world is a package of interventions for rehabilitation, so that at the end of the day, ministries of health can not only plan what are the interventions that need to be provided at primary, secondary, and tertiary level and delivered at the community, but also make an estimation what is the workforce that is needed, what are the equipment and consumables that are needed, what are the assistive products that are needed, and the infrastructure, what at the end of the day provides a budget to the Ministry of Health that they need to plan in order to integrate rehabilitation into universal health coverage. And another tool that we are currently implementing in 17 countries is a tool for supporting ministries of health to strengthen the health system to provide rehabilitation services, is what we call Rehabilitation in Health Systems Guide for Action, and with the main purpose of support and make sure that the Ministry of Health can really navigate and see the concrete actions that need to be done in terms of governance of leadership, in terms of financing, health information system, workforce, and essential medicine and technologies, with the ultimate objective of having integrated and coordinated health services, including rehabilitation. And in order to give an indication of how this agenda of rehabilitation is slowly becoming a priority in health, is that when we started Rehabilitation 2030 about 3 years ago, when we launched, actually it was in February 2017, we have in that moment no country requests to strengthen the health system to provide rehabilitation services. Today, we have 44 countries asking that request, and WHO, with many of the other partners from the rehabilitation sector and beyond, is moving this agenda forward, and through these tools, then supporting countries to move it forward. That is all from my side, and I'm very happy to be here for the discussion. Thank you.
Okay, thank you very much, the three of you, Alarcos, Huib, and Chapal. We'll have a 10-minute question session and answers, 10 minutes only, meaning we have the chat room for the participants online, and I also invite the people who are sitting with me in Berlin. Maybe we can just for me, it's a bit more sympathetic if I know a little who's with me in the room besides my colleagues from HI and our organizers, Bezev. Maybe you can just tell me your name and your organization, please.
Hi, my name is Thilo, Jan Thilo Klimisch. I'm head of CBM Berlin office and advocacy officer, so working in the unit on advocacy and advisory for CBM. And I also would have a question. I can directly, or you first. Okay.
Hello together, my name is Miriam Meyer. I am also from CBM Germany, working in the same team as Jan Thilo Klimisch.
Thank you.
Yeah, I am Eva Fischer, and I'm based in Munich, head of advocacy of Handicap International Germany.
Hi, my name is Danae Rodriguez, and I'm a PhD candidate from London School of Hygiene and Tropical Medicine.
Hi, I'm Jonas Gewölb, and I'm Eva's assistant from Handicap International based in Berlin.
Okay, so we start with Thilo. Question?
Thank you. Yeah, I would like to pose a question to Alarcos. Thanks to all three for the very interesting input. Alarcos, could you give us some insights on the current discussions in Geneva, WHO, if there are still at all? I mean, most is focused, no doubt, on COVID-19 right now, but however, we have the ending disability action plan of the last years now, and normally at next year WHA, we should have yes, on the one hand, a report on the ending disability action plan, which has important aspects inside on the rehabilitation issues, and of course the discussions on a follow-up plan. Where do we stand with that? Thank you.
Mm-hmm. So thank you, and it is very straightforward. So the report to member states will be prepared in collaboration with all our regional colleagues, also providing input on how the agenda has been advancing over the last 6 years in the regions and in the specific countries. And also to mention that there has been, for example, in the Americas, is also a report on the Disability Action Plan for the Americas, just being discussed now during the committee of the agenda. So we put all this information together that is coming from the different regions, and we will prepare a report. How the agenda will move forward now in terms of really disability and rehabilitation will depend very much of member states. Of member states moving forward with additional or a follow-up resolution, probably not asking for an action plan, but potentially including actions in the resolution. However, I have to say at this point, we don't have concrete information of what will be the decision and the request of member states on how these agendas will move forward. I think what it has been in the discussion up to now is that what it would be perceived as a very positive development is to move forward at some point with a resolution on rehabilitation, and rehabilitation anchored in the universal health coverage, and as we have been discussing, with the narrative in the same direction as Rehabilitation 2030, and having a resolution for disability now also taking into consideration the current developments that are taking place in the disability agenda, including also the UN disability strategy, what is creating a lot of momentum in the UN system, as I mentioned today in the morning. But at this point, we don't have from member states any official statement of a specific request from resolutions. Thank you.
Okay, thank you very much. Alarcos, thank you. Are there any other questions from the online audience? We don't see any. Remember, you can put it in the chat box, your questions, even now in the workshop, the answers you have or recommendations. In the groups, there's no question either, so I guess we can move forward. So the guiding questions I was talking about, we have 4 guiding questions to the subject. And I ask you to write the questions, because we cannot write them. We thought we can write them in the chat box. So we have 4 questions, and I will give you about 5 minutes so you can think about it. And the people who are online, please, the participants online, to write your answers and recommendations in the chat box, and then we'll talk about it here. And the people here in Berlin.
It feels like an exam.
Yes, it's interesting, a hybrid working group. Okay, the first questions, exactly. Why have the components, rehabilitation and assistive technology devices, received so little attention so far? So it's the why. Why have they received so little attention so far? So I would say more a question on a health ministry level, policy level, WHO. Well, we'll see. Everybody can answer. The second question is the what measures should be taken to increase their significance. What measures should be taken to increase their significance? And the third question is, how can existing efforts and stakeholders be supported? How can existing efforts and stakeholders be supported? Stakeholders, all of us, WHO, NGOs, civil society, DPOs. How can existing efforts and stakeholders be supported? And the last one is, who are the key stakeholders? And what should they do? Who are the key stakeholders? And what should they do? So now we have the group here. Yeah? Yeah, so you, of course, just to explain you again a bit the setup, we're here in Berlin. Of course, that's easy. You can just answer directly. Then we have our 3 presenters who participate. And then we have the online participants, which we cannot hear and see. So when you write in the chat box your recommendation, so we want to be concrete now, or experience from the field, are very welcome as well. So you write recommendations or solutions. You have to write to which questions they refer to. But of course we go in order with the first question now to be answered. Why have the components rehabilitation assistive technology received so little attention so far? So maybe we have already...
One answer online that is really short, but I think it's really important, and it's lack of data. So for the first question, I think the answer is lack of data. And also, yeah, no one, that it's anonymous.
The people, I forgot to say, the people who answer, please, so to make it a bit more personal, the name and the organization you're coming from. Yeah.
Yes, and the second answer we have here is from Christine Wegner-Schneider from Caritas Germany. And she's saying, Chapal spoke about technology divide between North and South, and Huib presented rehab as a tool to overcome of sorts this technology divide. Can it be seen like this? So maybe it's an answer and a question as well.
Alarcos, do you want to answer to this, or is it referred to the presentation of Alarcos?
No, it refers to the presentation of Chapal and Huib, actually.
Yeah.
Okay. Yeah, it is. We see it as one option, but as we've also made it very clear in the presentation that even rehabilitation has not reached to everywhere. So we have to see that what are the other options also available. So from the assistive technology side, we look for what is the best possible entry point and who is there. For example, primary healthcare, community-based rehabilitation workers. So what exists there, how we can mainstream there. Because if we wait for ideal world, that will take a long time. So it's whatever we can do right now, based on existing available facilities and opportunities, just integrate this and try to cover or bridge the gap. But at the same time, we also seeing that different way of doing it, and digital technology gives us an opportunity to really reach more people at a quicker time and give some remote support. So in fact, I can give you an example. WHO hired a artificial intelligence company, so they are developing those kind of a machine learning system based, and there will be a support mechanism by expert professionals. So anywhere in any PHC or any CBR program, if they come across some kind of a difficult condition, or they come across something which they do not know, or they want to be sure, there will be some mechanism to support that. I think we have to really embrace more technology, apps, remote support, artificial intelligence, because physically it is impossible. I don't foresee even in next 50 or 100 years we'll be able to have enough workforce to meet the demand. As Alarcos said, demand is increasing. but the workforce is not increasing proportionately. The WHO said there is a 20 million shortage of health workforce. So in this kind of scenario, we have to see what's the best way, how we can maximize our expertise and at the same time maximize the local possibilities. So we are really trying to see what are the local solutions and how best we make use of that. Over to you, Huib and Alarcos.
So Chapal, just don't want to cut you off. Do you have maybe a short and easy or like a recommendation or really or a reason, like a why, like just something we can stick on a piece of paper and have it?
Is the to your question one?
To have one short answer on the why, like something which sticks out, because we are kind of collecting later for the presentation of results of each question. We would like to have some points.
I think all of us will say that not a priority, of course, is it not? It's not a...
It's not a priority, and I think one of the main reasons I think we have to admit that it is because rehabilitation, and exactly the same like assistive technology, has been seen as a minority issue for a long time. And I think it has been also very much linked. So that is one reason. And if you have to put something on the wall, put that in big capitals, because it has been seen as a minority issue. And actually what the numbers demonstrate, and where we are going to with increasing numbers, Chapal said, the aging population, also the increasing number of people with NCD, also still many people living with the consequences of injuries and so on. This is not a minority issue. It are essential health services that need to be provided for the whole population and need to be available for the whole population. That is one reason. Another reason is that also, because it has been seen very often as a minority issue and as exclusively a disability issue, then this has created uncertainty of who is responsible at which ministry. So in some countries you say, okay, rehabilitation and assistive technology, not an agenda of the Ministry of Health, but it is an agenda of Ministry of Social Affairs. But if you go to Social Affairs and Social Affairs says, no, it is an agenda of the Ministry of Health. I think we need to be very clear with the narrative that we have, and that rehabilitation and assistive technology are integral part of universal health coverage and need to be under the stewardship and leadership of WHO. Even if some services, of course, are covered and are financially supported by social affairs, but still the stewardship and the leadership needs to be the Ministry of Health. And that is something that is still creates certain uncertainty and confusion. So that would be for me one of the second main reasons.
Okay.
And then of course you have many smaller ones that I could mention, but let's move on.
Like we have to unfortunately move forward, but very thank you very much, and I agree from my experience in the field as well. It's simply under the wrong ministry. People are not sensibilized, so I think we have still to do a lot of sensibilization on community level, on all levels, on what is disability, and that what is rehabilitation, what can be done, or that something can be done about it. It's not a disability which stays like that. Someone is disabled and nothing can be done about it, but it can happen at something can be done about it, like with rehabilitation care, like with physical therapy, for example, and it has to be on the right ministry. And that would be my addition. Sensibilization, data collection would be more than also the measure. But we have one question, one comment from the audience.
Yes, we have two more answers online. One is referring to question A. I read it out. It's from Inge Grönewegen. from the Lillian Fund. And she's writing, rehabilitation and assistive devices are seen as a luxury service in countries that struggle to deliver health services to persons without disabilities, and as a result, they are deprioritized. So I think it's the same direction as Alarcos said already. And we have another answer to question 2 from, let me see. No, there's no name written, but the person says that for question 2, what are measures to be taken? We need more data on effects of rehab interventions on population needs, but also keep supporting rehab strategies and resources allocations like human resources and financing. And then maybe we should use new technologies like tele-rehab as a part of the solution to reach more remote populations. So that should also be an answer to question 2.
Say at this point, if there are not any other answers to question 1, the question 2 you remember was what measures should be taken to increase their significance. So we did say sensibilization activities, data collection. Maybe Alarcos, if you want to talk about concrete tools like the STARS assessment, the standard assessment of rehabilitation systems, or do you want to touch that to explain, since it's a WHO tool? I'd rather have you.
And you know, I think that we can go through all the tools that both that we at the from the perspective of assistive technology, but also from the perspective of rehabilitation, we have been developing many technical tools to support countries, and I think there is a number already from them that with which really we need to move forward, and also to emphasize what I said briefly in my presentation, and as you mentioned also, that it is about, on the one hand, advocacy and evidence-based advocacy, and on the other hand, technical capacity. And of course, the guide for action, that it is actually accompanying and providing the tools that are necessary for the process of assessment, then implementation, and then monitoring, is a fantastic tool at the system level and for countries and ministries of health to move forward with it. And again, the package of interventions is another one. The list of assistive products is a very powerful tool also to move the agenda forward. So it is really the combination of both what we need: advocacy and technical capacity and technical work there. Thank you. And of course, another fundamental one, if I may say, is Uta. If another fundamental one, if I may say, is that all stakeholders move forward in the same direction and with the same messages and the same narrative. That is fundamental, because otherwise we will perpetuate confusion, and that is not what we want. So.
And all stakeholders, meaning exactly then NGOs, international NGOs working in the country, working with Rehabilitation Association, with the Physical Therapy Association, with the Association of the
all
PNOs.
Organizations, research institutions, NGOs, international NGOs, but also development partners. We should not forget also our the funders of moving this agenda forward. So everyone get help as stakeholders, and everyone should move in the same direction with the same narrative.
Yes. Uta, can I add to that as well? Because I think also that the corporate sector is also a very important stakeholder. Because I think as long as we have multinationals who are determining the high prices Chapal was referring to, I think these wheelchairs of 3,000–4,000 euro, they don't become available actually for people in low-income countries, full stop. I think it's extremely important that we motivate countries to develop their own industries, independent from Western or Northern businesses.
Yes, thank you. Yeah. Do we have, you have a question, answer for us, a recommendation?
Yeah, I could try and answer the question too. We had the question, what are the measures should be taken to increase their significance, the relevance for rehabilitation? And I was just thinking, I mean, sadly enough to say, but it always is relevant what kind of economic costs are reduced or produced or can be, what kind of economic growth can be achieved by, example, investing in rehabilitation. So what does a country actually lose on economic development if they don't invest in rehabilitation? If we look at education possibilities or employment possibilities for persons who don't get this kind of support, we all know it, and if we have the data for it and the numbers actually, what it means for a country not to invest in rehabilitation, then we could maybe increase the significance a little more, and maybe we have to communicate more on this topic as well. Just an idea.
Yes, I guess the answer is really working all on the same goal all together, DPOs, international NGOs, local NGOs, on all levels, with the Ministry of Health, that we really include all in all our projects of INGOs, working with the ministries to advocate for rehabilitation being a continuum of healthcare and being part of healthcare under the Ministry of Health. And here I would maybe like the importance of data, which was also an answer, just to highlight, which was presented by Valentina Pomato from HI, the tool we had developed from HI to improving financial access to rehabilitation, which is an economic diagnostic. We have done studies in 9 different countries, but just briefly, it's a diagnostic on the financial situation, on financial access, meaning the cost of a whole diagnostic of all levels, like the transport, the session, the physiotherapy session itself, the assistive device, and with this, the result, the outcome of this diagnostic, we have developed an advocacy tool to which we use also when we work on with ministries on elaborating and developing the national plan of rehabilitation to be included in the health plan. Okay, I think we can move forward. If there are not any other questions from the audience in the chat, we can move to question 3. Yes, Ira?
Yeah, I think we are already over the time. I think we have to stop at that point. Yeah, because we have already 3:45 and we have to go downwards now and present our results. Okay, I have one more question in the chat for Huib, and a question of understanding. Maybe you can answer it very shortly, but Prakash from Australia is asking, how can we ensure the quality of rehabilitation services with rehab? Information create awareness, but how to fill the gap between the gap of rehabilitation professionals? Thank you.
Yeah, very clearly, the rehab is just one of the many tools that is available. I'm not saying it is the tool, it is the best tool, it's the only tool. It's one of the tools that's at our disposal. But we do need also rehabilitation professionals. But as Chapal was saying, and I fully agree with him, it's going to take probably another 100 years before we are able to sufficiently get these numbers that are being required. So I think we must really try to bring everything on board to make sure actually that we are reaching as many people as possible.
Mm-hmm. One thing I just, time short, but one thing I want, look, what is happening in the COVID scenario? Suddenly these top 10 countries have put so much money on COVID, right? So why don't we target these top 10 countries who is making such a significant contribution for COVID? Also make some contribution for rehabilitation and assistive technology. why these are not in their agenda. In the COVID also, we have seen the older people, disabled people are suffered the most. So why not these can be in their agenda? If you look at the HIV/AIDS drugs 20 years ago, what price it was available, what price is today. We, in our department, every day we are talking, when they said COVID vaccine, it was saying $100. Now it has come to $3. How that is possible? Who is making it possible? So if $100 can become a $3 or $1 product, so we can finance rehab also, we can finance assistive technology also. The thing is, those development agencies who are manage the big money, they have to understand its value. Otherwise, we can go on producing documents, tools, and all. And Alarcos, we are doing this business for a long time, but it's not getting the traction. The traction is, how can we make HIV/AIDS drug, which was $15,000, today it is a $10? How we can make vaccine in COVID in $3? How is this happening? These big governments are cooperating, partnership, and putting money together to make a big change. And this is what we have not seen in our lifetime in the field of rehabilitation and assistive technology. Alarcos or Huib, please.
Unfortunately, we have to wrap up because we still have. Yes, we still have the results. I just want to, just as a resume, we talked about data collection, sensibilization, ministries. We'll all put it down. Just what we maybe didn't talk much. I personally, agree with, COVID-19 has also given us the chance, for us, an entry point into tele-rehabilitation. And I think this will help us all also, to really work with communities and community leaders, and really for them also to support us, and will give us also has given us. I mean, many NGOs have used new technology, or it's not new technology, like WhatsApp, tablets for data collections, or for example, some projects to show specific exercises to families who are isolated. I think new technologies is also a way, in the end also, which helps us for advocacy, but also to give access to beneficiaries. And they are just also from, of course, I wanted to just mention also the 3D technology when we talk about assistive devices to fabricate prosthetics and orthotics, to give access, home-based access to assistive technology with 3D printing, and other INGOs have same other initiatives, and to think of new technologies. I think that's also a way. Alarcos, do you have any last point to say, or Huib, or anybody and any pressing point or comment from the audience? No? Okay, thank you very much. We'll have now the half an hour results, all together. Thank you. Thank you for all.
Thank you to everyone. Yeah. Thank you, and also thank you to you.
So see you now, See you now in a minute,
Yeah.